My talk, please. So actually, my talk follows on very nicely from the previous speakers because it also addresses the challenges of below-the-knee interventions. And we know that below-the-knee interventions have specific challenges, including that they tend to be small in diameter. There's always a high incidence of medial calcification because most of them are either diabetics or have renal impairments. They tend to be long and they have multi-level and multi-territory distribution as well. And we've heard sort of in the previous from the previous speakers as well, the chances of dissection, recoil, perforation, thrombosis, embolization. But more importantly, there is not really long-term data on any of the novel technologies, including the calcium modifications. And this is probably one of the potential areas or potential advantages of the intravascular lithotripsy. For those who are not familiar with the technology, I thought this video might be helpful. So the concept of lithotripsy is not a new one. It's been there for years, using the extracorporeal lithotripsy to treat the renal stones. The idea is that in most of these devices, especially for below the knees, they are 014 platforms. And the idea is that you inflate the balloon and it has to get in contact with the arterial wall. So usually we size it 1.1 to 1 in terms of the diameter. And for below the knee IVL or shockwave balloons, they have 4 emitters. And these emitters generate pulse wave, ultrasonic pulse waves. For the S4, which is the below knee devices, they can be delivered in 10 pulses per cycle, 20 pulses per cycle, and you can go up to 160 pulses per balloon. And when you the emitters start deploying the cycle, they generate a bubble, and this bubble transmits the sonic waves to the wall of the artery through the balloon. And when it's delivered in the wall of the artery, it tries to produce some cracks in the calcium in the arterial wall. And essentially, by squeezing the calcium in the arterial wall, this causes cracks longitudinal and transverse. But also, these sonic waves get reflected when it reaches the natural or the arterial wall. And you have 2 diverging waves now, and this causes expansion of the cracks of the wall of the artery. So just to simplify it, it's like turning a bag of stones into a bag of sand. And what happens is that this bag of sand becomes more compliant. So you can shape it, or it will be more responsive to the definitive treatment that you're thinking of. And certainly when we use the IVL, we don't use it as a standalone treatment. And as I said, the balloon for the infrapopliteal segment, which is the S4, has 4 emitters. And you can move the balloons to position the emitters to deliver the treatment in the very calcified areas. So what's the evidence? This is the big sort of drawback in terms of using this technology. So there are only 2 papers published so far. There are lots of studies. We've heard of Mariano and Bruno are working on one now, but what's published are just only 2 papers. The first one is the pilot study, which is published in 2018, and they looked at 20 patients only. The idea was just to prove that this is a safe technique. And when you look at the selection as well, so they chose small lesions, so 5 centimeters, with the 7 centimeter sort of extent of calcification. But nevertheless, there were almost like 50% reduction in the degree of stenosis. And noticeably, there were no perforation, distal embolization, or thrombus. There's only 1 dissection. And this is maybe because the balloons are usually inflated at a very low pressure, so it doesn't cause significant barotrauma to the arterial wall. And based on that, sort of these 20 patient series, it was obvious that this is not a relatively safe procedure or technique to be used. And this led to the second publication, which is a subgroup analysis of the Disrupt PAD3 study, which is a single-arm study using the IVL as a vessel preparation. And they identified 101 patients who had infrapopliteal disease as well. Around a third of them had claudication, so the vast majority were CLTI patients. And again, when you look at the lesion length, they were not necessarily the longest, certainly not the cases that Mariano and Marco have been showing us, but they were calcified. And despite the fact that the centers reported the significant calcification, all of the patients, the core lab assessment showed only that 80% of them had significant calcification. And in quarter of the patient, they required another calcium-modifying treatment, but in 3/4, the IVL was enough to deal with the calcium. And when you look at it, you can't really miss the fact that there were no reported complications, the ones that we fear from the infrapopliteal treatment, where no perforation, no distal embolization. There was no flow limiting dissection, but actually there were 3 dissections which required stenting as well. But what was obvious is that there is a significant improvement in terms of luminal gain before and after using the IVL balloon. And certainly it gets even better with the application of the definitive treatments. So based on that, it's sort of a subgroup analysis. It's another addition to the fact that this is a safe treatment modality. All of these are acute results, so it's not a long-term ones. So I tried to sort of portray a balanced view. So I've reached out the Shockwave colleagues, and they were happy to share with me the latest presented data from the Disrupt PAD below the knee 2, which was recently presented at CIRSE. And this is more of like a real life data, but this is only procedural outcomes. Again, sort of like 250 patients, and the usual risk profile when you deal with below knee disease. Only 4.9, so 5% required stenting, which is a reflection of the fact that because of the low pressure, the prolonged dilatation, you're less likely to require or to produce dissection. And again, if you look at the right side, there is a significant improvement in terms of luminal gain after the use of the IVL balloon compared with before. And again, the fact that the rate of complications are quite limited, and this includes dissections or perforations or thrombosis or vessel occlusion. So there is certainly lack of long-term data, but all the initial data from the acute procedure outcomes are very promising. So how does it fit in my practice? I think, so Mariana showed us a very nice case for below the ankle IVL, and I think probably there is a role that could be played with the Shockwave or IVL balloon or lithotripsy in general in trifurcation or bifurcation lesions, for example, or if you try to use plain balloon and this doesn't respond well. So this is an example. I think this is a good case where you can use the IVL or the lithotripsy concept as a whole, because I always struggle with these bifurcation lesions, because if you treat one side, you worry just with plain balloon even, you worry about plaque shift, and this can compromise the other side. If you stent one side, then you probably can compromise the flow on the other side. You might end up either putting kissing balloon or kissing stents, and this can have competing pattern of flow within the main trunk of the TP peroneal trunk. So if you can do something which can change the conformability of the lesion without actually compromising the other branch, that will be ideal. And for this one, we use the S4, which I mentioned before, and we use it as a vessel preparation, again, not a standalone treatment. So we do that, and then we go back again and use either plain balloon, or if you fancy stenting, you can do that. So this is how we started, and you can look at the difference in terms of how the vessel looked like after the IVL followed by plain balloon angioplasty. So just to conclude, if you look back again into the slide which showed the complications or the risks associated with below knee interventions, I think there is a potential benefit, and I'm saying potential benefit because we're still waiting for the long-term data for using the IVL. Certainly, it addresses small diameter vessels because it comes with different diameters from 2.5 to 4. It's certainly probably one of the best options to deal with medial calcifications, and certainly has low risk of dissections, recoil, perforation, embolization, and so on. This is because, as I said, it's a low pressure inflation of the balloon for a prolonged period of time. What we're waiting for is the support or the evidence to show that it can actually deal with long lesions. And because of the short length of the balloon, you might have to use it in multiple times or maybe more balloons. However, having reached to the manufacturer of these balloons, now they are coming out with the 80 millimeter balloons, which have more pulses as well, so 400 pulses, which can lead to the fact that you can use just one balloon to treat long segment, which can also address the multi-level and multi-territory lesions. Certainly, we need long-term data to judge on the effectiveness, and certainly we need some comparison between those different calcium modification techniques, including the atherectomy and the lithotripsy. And thank you very much for your attention.